No, I'm really grateful to be in this beautiful location. And so here, my task is to present some of the exciting updates in multiple myeloma and how I think about how do we apply those updates to current clinical practice, practice in the community, practice in major medical centers. So here's my disclosures. So I know I only have 30 minutes, and so I'll try to cover as much ground as possible, but realizing that I may not be able to get through all the topics. So here in multiple myeloma, we're really fortunate to see kind of an avalanche, pun intended, or maybe that's not a good pun, but anyway, and just a wide array of new drugs available really in the past 5 to 10 years. And the challenge is, how do we incorporate these therapies into current clinical practice? And so here we think about the three core pillars of multiple myeloma therapy. We think of the IMiD drug class, we think about the proteasome inhibitors, and CD38 antibodies. Those are sort of when people talk about triple class, exposed, refractory disease, they're talking about these three classes. But I'm going to propose to you that the BCMA is going to be the next fourth pillar of a table, not a stool, right? It's going to be the fourth leg of what I think about as myeloma therapy. So treatment of newly diagnosed multiple myeloma. So I think one of the big changes in the past 3 to 5 years has been moving from 3 drug therapies to 4 drug regimens. And that's really with the advent of the CD38 antibody daratumumab, and that's really been accelerated by the subcutaneous formulation of daratumumab, which was approved in 2020, and which really facilitates the logistics of giving this monoclonal antibody in routine clinical practice. So here we have, I just put as a reference point the determination study, which looks at the incorporation of autologous stem cell transplant. I won't talk about that necessarily, but then here I talk about the Griffin study, which was the first study to look at DARA RVD versus RVD. Now granted, the disclaimer is that's a phase 2 study, so there are limitations with interpreting a phase 2 study, and the primary endpoint of that was stringent complete response. But here you can see that when you add daratumumab to RVD, you can see significant improvements in progression-free survival, and that's also reflected in the improvements in depth of response. And there are some ongoing phase 3 studies to help confirm the addition of using an anti-CD38 antibody. So we have the Perseus study, as well as the GMMG HD7, which is using Cetuximab, another anti-CD38 antibody. And there was some data that was presented last year, or a year and a half, in 2011, that showed that addition of Cetuximab to RVD really improved in terms of meeting depth of response in terms of MRD. So essentially, these studies are informing, or have already informed, the usage of a 4-drug regimen in newly diagnosed transplant-eligible multiple myeloma patients. And another regimen to think about is DARA-KRD, which is instead of using bortezomib, carfilzomib. And I recognize that there's a lot of variation in clinical practice in terms of usage of bortezomib versus carfilzomib in newly diagnosed patients. But here I just wanted to point out that these are regimens, weekly carfilzomib, and you can see significant improvements in terms of depth of response when you incorporate carfilzomib as part of a regimen for newly diagnosed patients. So it's just here to show it is another option. And then in transplant-ineligible patients. So of course I would be remiss in saying, of course it's going to come up, but what about RVD light because of a person in the room, i.e. Dr. O'Donnell? He's been, she put RVD light on the map in her phase 2 study. So I recognize that there's a, well, I'm not good, well, there's a, I was going to say elephant, but maybe that's not really, I don't want to say she's an elephant, but you get what I'm saying. But there's not morphologically an elephant, but metaphorically. But so here this is informed by the phase 3 Maya study, and there have been several updated looks at the outcomes of the patients. But in my sense, the bottom line that when you add daratumumab to the RD backbone, you can see significant improvements in response And that's reflected in improvement in PFS as well as overall survival. I mean, to have this degree of overall survival, again, in a transplant ineligible, an older, frailer patient population, I think it's unprecedented. And another thing to point out is that the addition of daratumumab, also you see benefit in high-risk cytogenetics. People talk about, proteasome inhibitors are key for treating high-risk cytogenetics. We think about deletion 17p, 414, 1416. But here you can see that daratumumab also is efficacious in high-risk cytogenetics. And this was it kind of doesn't project very well, but this is progression-free survival and overall survival. So in the recent ASH meeting, there's some studies that inform how do we use DARA-RD and make it more user-friendly. Now, just as a reminder, the initial Maya study looked at daratumumab intravenously, and the lenalidomide was 25 milligrams. And of course, the myeloma therapy, we love to include dexamethasone as part of the regimen. But at some point, it's sort of like salt or bacon. You can always have too much of something. And so here, this is a phase 3 study that looked at DARA-RD in an older, frailer patient population, and the dexamethasone in the DARA-R arm was just cycles 1 and 2 only. So just the first 2 cycles, and then lenalidomide omitted. Then the dexamethasone is omitted. And here you can see that even though you omit the dexamethasone, you see, again, it maintains the response even without the dexamethasone, and that overall it was well tolerated. So again, dexamethasone sparing regimens, I think this informs the practice of using this regimen. It maintains efficacy and reduces toxicity in this frailer, older patient population. So this is one approach to clinical practice. I'm not saying this is the approach. This is just one approach of many. And this is just one framework for thinking about how do I approach newly diagnosed myeloma patients, in 2023. So I think for fit younger patients, I tend to think about, DARA-KRD, mainly because it's the weekly carfilzomib regimen. Because I'm just thinking, the studies with DARA-RVD, the Perseus, Griffin, it's twice a week bortezomib. But here, you allow patients to do a once-a-week regimen, which I think is more user-friendly, maintains the efficacy, as well as avoids some of the adverse events, such as peripheral neuropathy with bortezomib. But I do recognize that choice of this depends on what your local practice is comfortable with, as well as insurance coverage. And then we always think about autologous stem cell transplant as part of the therapy for newly diagnosed patients. Now, in fit older patients, you don't have to this isn't necessarily a mutually exclusive zero-sum game. It's not always you have to choose like DARA-RD or RVD Light. Why not combine both of them? You can make everybody happy. And so for fit older patients, my practice has been to do like DARA-RVD, but in this case, the bortezomib is on a weekly basis. And then for less fit older patients, I use DARA-RD, but again, the dosing of lenalidomide used at 15 milligrams, not 25. And the dexamethasone given only in the days of treatment. But as you saw from that IFM study, you have the option to peel back dexamethasone. So I think the important thing to realize is that in clinical practice, the dexamethasone gets tapered off relatively quickly as opposed to what's written in the protocol. And then for ultra frail patients, I think daratumumab sub-Q as a single agent works great in terms of the tolerability and efficacy, and always considered clinical trials. So what about relapse after 1 to 3 prior lines of therapy? And again, there's so many options you can choose from that initial slide that I showed. And here I just sort of summarized in bar graph form kind of the different treatments you can think about. So the common theme here is an anti-CD38 antibody, and then you can either combine it with pomalidomide or with carfilzomib. And I guess, this is kind of a busy slide, right? But I think one thing to point out is that you can see that in the carfilzomib-based arms, that there is this significant improvement in progression-free survival, as well as in the depth of response. But something to point out when you think about these clinical trials is that in the carfilzomib-based trials, they were generally lenalidomide. The amount of prior lenalidomide exposure was relatively small compared to the pomalidomide trials. When the pomalidomide-based trials, all patients had to have prior lenalidomide. So in a way, the patient population was not as heavily treated. But nevertheless, in the lenalidomide refractory cohort, the carfilzomib-based arms continued to perform well. So what's one approach to clinical practice? So I think just as an overview, I acknowledge that the CD30 antibody, I acknowledge that the carfilzomib probably has a little bit more juice in terms of efficacy compared to pomalidomide, all things being equal. But at the same time, we also have to think about the logistics of giving the treatment as well as the patient experience. So for me, the logistics, carfilzomib requires an intravenous infusion, whereas pomalidomide, it's an oral regimen. So as well as the schedule, the number of visits required, using daratumumab or with pomalidomide, the schedule is easier for the patient compared to a carfilzomib-based approach. So I think the convenience is key here. But at the same time, also with carfilzomib, I think there's always been some, carfilzomib does, it's more effective, but there's a logistics issue, and then there's always the concern about the adverse events with the cardiac toxicity. So in the Candor and IKEMA studies, there was, grade 3 to 4, heart failure 4 to 8%. So that is a little bit of a friction point with using carfilzomib. But at the same time, those are those clinical trials, and I think in current clinical practice, like how are we actually using it right now? When you're using it weekly and with attention to not overdo it on the hydration, the actual amount of adverse events, I think, from that is much less than reported in the clinical trials. So again, this is just a framework for thinking about this, and again, you have to individualize it to the patient, right? So patients, there's differences when I think about a patient who has a biochemical relapse versus a patient with a clinical relapse, which is more aggressive, so you can pick the regimen based on those characteristics. So anti-BCMA CAR T cells. So this is sort of the hottest topic right now in multiple myeloma. And let's just start off with thinking about BCMA. Like, what is BCMA? So BCMA, it stands for B-cell maturation antigen. I think this doesn't project very well, but the point here is that BCMA is on the surface of plasma cells, it's on the surface of myeloma cells, but is also on the surface of B cells upstream of plasma cells. So this does factor into how I think about the adverse event profile in terms of risk for infection longer term. So again, it's another cell surface protein, kind of like CD38 is a cell surface protein on plasma cells and myeloma cells. And here we're fortunate now to have two CAR T cell therapies approved for use in multiple myeloma. We have, ide-cel, which was approved in March of 2021, and then last year we have cilta-cel, and the approval again is for 4 or more prior lines of therapy and this triple-class exposed patient population. So let's just kind of run through how the logistics of CAR T cell therapy. And I know maybe this is a bit preaching to the choir here because it does overlap with usage of CAR T in lymphoma, but again, we think, the approval and then the identification of patients is key. So can the disease be kept in check while waiting manufacturing? Because the manufacturing can be 4 to 8 weeks, and in the initial rollout of ide-cel and cilta-cel, the manufacturing could be as long as 2 months. So you have to identify the right patient who's able to be maintained while the cells are being manufactured. Also, can the patient be in relative proximity to where the cells are being given, as well as is there adequate caregiver support? When patients undergo, after apheresis, patients generally as need to receive bridging therapy, and then there's a lymphodepletion where they have 3 days of let's say, typically fludarabine and cyclophosphamide to kind of create space for the CAR T cells. They receive the CAR T cells generally as an inpatient, then there's monitoring for adverse events like CRS and neurotoxicity. But I think the key selling point for both the clinician and the patient is it's this idea of one and done, right? By the time the patients get to CAR T cell therapy, where they've had 4 prior lines of therapy, as much as they enjoy seeing Dr. O'Donnell, they might say, well, I don't like seeing her that often. And they do like the idea of just having one therapy and being observed. I mean, that's a game changer for a myeloma patient, right? Being able to have one therapy and just be observed. I mean, it just changes everything for the patient. Though, of course, I do acknowledge that there are clinical trials looking at maintenance as well, which does change that appealing feature. So here I show you the efficacy of ide-cel and cilta-cel, and then here I show kind of the baseline patient characteristics. And again, I think in common for both, they're really heavily treated, 6 prior lines of therapy, triple-class refractory. Though I do wanted to point out that for the ide-cel patient population, those patients were, maybe a little more heavily treated than the cilta-cel patients, in the sense that there's more extramedullary, had more aggressive disease features, more extramedullary disease, high-risk FISH, as well as the response to bridging therapy was lower. So that might potentially explain some of the differences in outcomes, or account for some of the differences in outcomes between ide-cel and cilta-cel. But here, nevertheless, you can see in this heavily treated patient population, a PFS that would not be obtainable with the standard of care product at that time, or as we heard, this BAT, I remember best available therapy. I should use that more often because you can think of all these funny puns you could use with BAT, or memes. But I don't know, I don't see that used in any myeloma literature, but BAT. But anyway, you can see, but I think for cilta-cel, a 2-year PFS, that's amazing, right? Again, a patient who's been through so much, and then they can have 2 years of one and done. Incredible. And this also is reflected in the improvements in overall survival here. Just as a reference point, in these other therapies that are approved in a similar patient population, doesn't quite achieve that degree of overall survival exceeding 2 years or more. But what about the adverse events? Because there's no such thing as a free lunch, right? And the main things we think about with CAR T-cell therapy across the board, myeloma, for lymphoma, would be CRS and neurotoxicity. So nearly all patients will have some evidence of cytokine release syndrome. Usage of supportive therapies like tocilizumab, corticosteroids is really common. And then we also think about this neurotoxicity, or ICANS. And that can be a big spectrum of ICANS. And we'll hear more about this in the lymphoma talk, because CAR T was first developed in lymphoma ALL. So the neurotoxicity piece can be really variable in terms of having confusion to this movement and neurocognitive changes, which I don't think has really been described with CD19 CAR T. And so that's just something that provides an additional layer to when you think about CAR T-cell therapy, where you had 5 patients in the cilta-cel group who developed this kind of almost Parkinson-like movement disorder adverse event. But it's not, the pathophysiology of it isn't like Parkinson's in terms of, patients could get carbidopa, levodopa, but there's no response. So this is sort of the beginning that this is sort of the initial findings, and it's also been seen in ide-cel. Well, it's not unique to cilta-cel, so it has been reported with ide-cel as well. And the hope is that with better patient management strategies, the risk of having these unusual movement is only 0.5%. So I think as we get more experience and figure out how to better manage these patients, I think that risk will be less over time. So outcomes of cilta-cel compared to real-world clinical practice. So this just kind of sets the stage for, and this is, when cilta-cel, and this is a retrospective cohort, you can see with a PFS or overall survival, again, much better than what you would see in compared to standard of care therapies that are available at the time. This is based on locomotion, which is mainly European-driven cohort. And also, what are, now that ide-cel, that we had ide-cel available for over a year, how does it perform when we actually use it in our real patients, not clinical trial patients? Because, when I think about patients who go in clinical trials, these are carefully groomed, hand-picked patients that cross T's and dot I's. And we all know that patients in real-world clinical practice, they're a lot messier with more real-world problems. And so this was a study of about 196 patients where ide-cel was used in patients in real practice. And here you can see that about 3/4 of these patients would not have qualified for a clinical trial for various reasons, functional status, cytopenias. And that these patients had more higher risk features, including prior BCMA therapy, than in the KarMMa clinical trial. But I think what was impressive to see is that the performance of ide-cel was maintained even when you have these so-called messier real-world patients. And I think it'll be interesting to see how the cilta-cel performed in real-world practice as well. So, of course, these clinical trials, we're looking at ide-cel, cilta-cel, in patients who've really been through a lot of therapy, triple class, exposed, median of 6 prior lines of therapy. But as with all therapies, why not try it sooner? Why wait until then? So here we're starting to see initial data looking at these CAR T-cell therapies in earlier lines of therapy. So this is just hot off the press. This was a study that was presented last month, the KarMMa-3 study, which is the first phase 3 randomized study in multiple myeloma of a CAR T-cell therapy. So in this study, looked at 2 to 4 prior lines. These are triple class exposed. So again, 2 to 4 prior lines. And triple class exposed, now that we're using CD30 antibodies earlier in earlier lines of therapy, newly diagnosed second-line therapy, we're going to see this patient triple class exposed, this patient population is going to become more and more the norm. Randomized study, and what were the outcomes? So again, you can see when you used ide-cel in this patient, much deeper responses compared to the control arm. In the control arm, the standard regimen were these regimens, some of which we do use in actual clinical, which we do use. And in 60 patients, the control arm did receive ide-cel progression. But I think, nevertheless, at 13.3 versus 4.4, it's a significant benefit. And again, for this patient population, they've been triple class exposed. I think there is going to be an appetite to use this from both the clinician and from both the patient to be able to have this one and done therapy. And then the CARTITUDE-4 study, this was a press release in January. The study, so they just presented saying, hey, this study looks positive. So this is something we await presentation of more formally. So again, the study design is sort of similar to KarMMa-3, but the key distinction here is that these patients were lenalidomide refractory in the CARTITUDE-4, again, the cilta-cel. They were not daratumumab exposed. So again, different patient population, different control arm. So everyone's really eager to see, okay, how does cilta-cel perform in this patient population? And then in newly diagnosed patient, the key is to figure out, okay, why not just use we had these amazing, incredible depths of responses. Because I'm just trying to think, would high-dose melphalan achieve a similar depth of response in 4 prior lines of therapy? Probably not. So it begs the question, how would this perform in newly diagnosed patients? So they have 2 studies, CARTITUDE-5 and CARTITUDE-6. So CARTITUDE-5 is looking at cilta-cel versus the standard care would be in transplant ineligible or not intended patient population. So I think the key here is cilta-cel one and done, right, versus being on Lendex until progression. In transplant, not intended, not eligible patients. So that's an ongoing study. And then there's the CARTITUDE-6, which is directly comparing cilta-cel versus autologous stem cell transplant. So that study is ongoing. So again, this is stuff to think about for the future. And then bispecific antibodies. Okay, so targeting B, you don't have to have a CAR T cell to target B. You have these other options too. I did point out belamaf as a reference point, but it is no longer available in U.S. practice because of the DREAM-3 study. So that would be a separate discussion. But we have the bispecific antibodies. So this is of intense excitement because this is something that's available. You don't have to, remember I showed you the slide of all the logistics involved. Patient selection, you have to wait for the cells to be collected, cells to be manufactured. There's all the logistics involved. And plus you have to go to a major medical center for that. And this is something that is available, that is more immediately available. And I think it tries to bring in the immune system, but also being more directly accessible and off the shelf. But because it brings in T cells, the toxicity profile does overlap with CAR T cells, such as cytokine release syndrome and neurotoxicity. So the Teclustumab was the one that's been studied the most. So this is Majestic 1. Again, 3 prior lines of therapy, triple class exposed, and the treatment is subcutaneous, and they have the step-up dosing to minimize risk of CRS. And here in this patient population, an overall response rate of 63% and a median PFS of 11.3 months. Again, in this triple-class exposed patient population, really impressive results. Now, again, no such thing as a free lunch, so there is risk of CRS and neurotoxic, but not as much as compared to CAR T-cell therapy. So the cytokine was about 72%, and the neurotoxicity was less. Now, one thing to point out, though, is the side effect profile relates to the fact that BCMA is across a lot of B-cell populations. So there is a higher risk of infection because you do see a hypogammaglobulinemia. So here in Majestic 1, there was about a 44.8% risk of grade 3 infections. Again, infections requiring hospitalization, a fair amount of hypogammaglobulinemia, PCP, and COVID infections. So it's also a little bit complicated because of the time when the study was being done was really in the heat of COVID. So now would you have the same infection profile in 2023? To be determined. So here I'm just showing how would Teclustumab PFS of 11.3 months compare to, again, the locomotion study. Again, you can see superior in this by comparison to real-world clinical practice, depth of response and outcomes. And so this was just approved in October. And a couple things to point out is that because of the risk of CRS and neurotoxicity, patients do have to be hospitalized pretty much during the 2 step-up doses and the first full dose. And here in clinical practice, because the dosing only has to be 48 hours apart, we give it days 1, 3, and 5, and if everything goes well, they could be discharged in day 7. So here, this is an area of active clinical development. There are multiple bispecific antibodies under investigation. So we have Teclustumab, elranatamab, a whole slew of bispecific antibodies. And right now it's too early to say, is anyone going to, are they more similar or are they more different? There are some differences in scheduling, frequency of dosing. So I think a lot of this is to be stay tuned. And then there's some ongoing studies in the same fashion of, well, why wait till you have triple class exposed? So there are ongoing studies looking at an earlier 1 to 4 prior lines of therapy. And here we have studies looking at Teclustumab combined with daratumumab versus these control arms, or elranatamab versus daratumumab. So again, seeing if we can capture that same efficacy. Maybe the efficacy will be better if you use it in earlier lines of therapy. And also we're looking at it in maintenance therapy. And then why not use it in newly diagnosed patients? So here is in newly diagnosed patients an ongoing study looking at daratumumab, Teclustumab, and lenalidomide versus DRD in newly diagnosed patients. So here I summarize sort of the how do I think about these different types of BCMA therapies? So I think with, again, the bispecific antibody, the fact that it's off the shelf, it's immediately accessible. And again, there is risk of CRS and neurotoxicity and longer-term hypogammaglobulinemia and risk of infection. And then we have CAR T-cells, which I do think offer the best depth of response, best durability of response available. And it has that key feature of one and done. But the main limitation, again, is access to this therapy and the logistics involved. So additional treatment options for relapse disease. So I'm thinking, okay, I just talked about all these exciting things like bispecific antibodies and CAR T-cell therapies, but the reality is it's not immediately available for everyone. For patients, for logistics, is it approved on the formulary? So I just want to point out just some other options that you can think about, like cyclophosphamide, Cellinex, or Phonetoclax. And here, I think cyclophosphamide, you don't hear as much attention about cyclophosphamide because, well, there's no industry sponsor for cyclophosphamide, right? But I think cyclophosphamide is a great drug to use. So this regimen, I just want to highlight, the carfilzomib with cyclophosphamide, dexamethasone, can be really effective for patients. So for the triple-class exposed patient, this regimen can be really effective so here this is a phase 2 study that showed that in this lenalidomide refractory cohort, significant improvement in PFS. And then there are other options like combining pomalidomide with cyclophosphamide, or then there's a study, the daratumumab. So these are studies just to illustrate that cyclophosphamide can be a really effective option while you're trying to figure out your next step, trying to think about CAR T or other or clinical trials, et cetera. And then Cellinex, again, this is an option that's available right now. And it's a pill, and it's really, so it does have that convenience. And I just wanted to point out, there's a Boston study that looked at a combination of selinexor, bortezomib, dexamethasone versus the control arm. But a couple things to point out in this study, that in addition to showing that selinexor improves the progression-free survival, that in the treatment arm, it's getting half the dose of bortezomib compared to the control arm. So the selinexor had to make up that difference. And by making up that difference, and also it goes above and beyond that. So it also points out that this is also weekly dosing of selinexor. But in actual clinical practice, in terms of when I use selinexor, it's really an either in combination with pomalidomide or carfilzomib. So here are some examples of arms of the STOMP trial that demonstrate its efficacy, including in a triple class refractory patient population. So again, these are options to think about that are available to you right now. You don't have to do a clinical trial. You don't have to refer your patient, drive in for 2 hours and find parking and find somebody to drive them, et cetera, right? So these are just things to think about. And then Phonetoclax, again, I know we heard about Phonetoclax from Dr. Graf's presentation, and I acknowledge this is an off-label usage. But Phonetoclax in the T1114 patient population can work remarkably effectively. And the Bellini study was a phase 3 study that was really informative in how we think about Phonetoclax usage. So one thing to point out here is that this is a randomized phase 3 study that, while it had great improvements of PFS, the overall survival didn't look so good. And because there was a temporary hold, et cetera, but unexpectedly worse overall survival. If you looked at the overall patient population, but if you looked at the translocation 1114, the responses were pretty remarkable. And so there are some ongoing phase 3 studies. There's an ongoing phase 3 study to better confirm that benefit. But I think this also established them of obtaining this FISH at diagnosis to identify those patients. Okay, so treatment's on the horizon. I'm getting some dirty looks, but well, I mean, you know what I mean. So, but there are all these new therapies about GPRC5D. These are all on the horizon that, bispecific antibodies. Of course, we have CAR T cells. Why not? That these are things that are really exciting, and Cevostamab, another bispecific antibody, and then there are newer generations of drugs that target cereblon and that are more potent, and so these are things that that could go beyond the IMiD therapy. So this is my last slide, and I will conclude there. Thank you.
Thank you. We do have questions, but we'll wait for the panel to address them.
Okay.